Okay, hi everyone. Thank you for joining us this evening for today's tutorial. Today's tutorial is on eye disorders and diseases given by Devika. Just a few rules for those of you watching on the Zoom. Any questions or comments you have, just pop them into chat or the Q&A. If you're watching on the Facebook Live, just comment your questions and we'll make sure that they're passed on. That's all from me, and I'll hand over to Devika to begin. Thank you.
Hello everyone. Thank you for taking the time and joining this session on eye diseases and disorders. Let's get started. So that's just a disclaimer from becoming a doctor, and you can have a read of that later. The learning objectives for today's session is to gain knowledge about common ophthalmology conditions, discuss various causes of red eye, and in general get an idea about how you'd manage ophthalmology conditions. So in order to achieve this, we're going to go through 9 cases, and hopefully after that you'll have a better idea of the conditions and how to manage them. If we're running on time, I might take a break in the middle, and we can, you guys can ask me any questions then. But always just put up any questions in the chat box, and I'll be happy to address them in the end. Yeah, so let's begin with case 1. We have Mrs. Johnson, who's a 72-year-old female. She presents with gradual reduction in visual acuity of the right eye. She has noticed that the light rays are shooting in every direction, especially at night. On examination, you note a loss of red reflex on the right side. The left eye is unaffected. What condition is Mrs. Johnson most likely to have? So while I put the poll up, take a minute and see what you guys think. So I'll give you guys like 10 more seconds to bring in your answers, and then we can discuss them. Okay, so I'm sharing the results with you guys now, and it's quite interesting because I think we've got 3 people saying open angle glaucoma, 3 saying cataract, and then a vote each for macular degeneration and acute angle closure glaucoma. So let's kind of discuss why it is what it is. So the actual answer is cataract. And I've highlighted in yellow the key features that make cataract the most likely diagnosis. So the fact that it's a gradual reduction, and she's noticing that the light rays are shooting in every direction. So this is also known as the starburst effect that's commonly seen in someone who has cataract. And another key finding of cataract is the loss of red reflex, as you can see with Mrs. Johnson. For someone presenting, well, no one said subconjunctival hemorrhage, so that's good. Acute angle closure glaucoma, you're going to see a patient that's acutely unwell. So they would have like a painful red eye, which in this case is not there. It's not going to be a gradual presentation. There's going to be something that's quite sudden. So you can rule that out. Open angle glaucoma and macular degeneration. I'm going to be talking a bit about these in the next few cases to come. And hopefully with that, you get a better idea of why it was cataract and not those. Let's talk a bit about cataract then. So a cloudy and opaque lenses, you're going to reduce the amount of light entering the eye, which will reduce your visual acuity. And as you can see on this picture, it's easy to appreciate the cataract on the right eye of this gentleman. The risk factors are smoking, alcohol, diabetes, increased age, steroids, hypocalcemia. So there's a whole host of things that can increase your risk. The clinical presentation, so it's usually asymmetrical. They're going to have a gradual reduction in vision, blurring of vision, starbursts, so that's the light rays that appear to be shooting in different directions, especially at nighttime. Change in color is not that common, but yeah, loss of red reflex is something that is commonly seen. In terms of managing, the management option is surgery, and that would involve implanting an artificial lens. So I've got another question for you guys. In which of the following pediatric conditions would the red reflex be present? And I'm just going to put the poll up for you. Right. Okay, so the majority of you said Wilms tumor, which is the correct answer. Yep, and I think this is just one of those questions where it's a fact that you guys need to know. So retinoblastomas, corneal clouding, and congenital cataracts, partially or completely absent red reflex. Wilms tumor is you should not affect your vision, so your red reflex should be fine. Moving on to case 2. Here you have Mrs. Singh, who is a 68-year-old gentleman, and he's presented with gradual peripheral loss of vision of the left eye. Additionally, he's been experiencing halos around the light and intermittent headaches. What condition is Mr. Singh most likely to have? I'll give you guys about 20 to 30 seconds to answer this, so take your time. Okay, so just a few more seconds. I think we're getting a couple more votes in. Yeah, so I'm sharing the results now, and the majority of you said open angle glaucoma, which is the correct answer. We've got a couple more votes one for cataract, retinal detachment, and age-related macular. So let's discuss why it is what it is. So again, I have highlighted the key features that make open angle glaucoma the most likely diagnosis. And the fact that it's a gradual loss of vision and a peripheral loss of vision makes open angle glaucoma more likely. He's also experiencing halos, and halos is a characteristic finding you see with someone who has open angle glaucoma. Retinal detachment, yeah, it does cause peripheral vision loss, but it's something that comes on suddenly. And as you can see here, it's a gradual loss of vision. Plus, you wouldn't necessarily experience halos in someone with retinal detachment. Cataract, so we just spoke a bit about cataract, and usually you would see starbursts, and it would be a gradual loss, but not necessarily of the peripheral vision. And age-related macular degeneration. So number 5, we're going to talk about it in the next one of the few cases. So hopefully after that you'll appreciate why it's a glaucoma and not AMD. So open angle glaucoma, risk factors is increasing age, if you have family history, nearsightedness, and Black ethnic origin. So do particularly note the ethnic origin, because when we come to the acute closed angle glaucoma, Black ethnic origin is not a risk factor. Clinical presentation, they're usually asymptomatic, diagnosed on routine screening. You have a peripheral loss of vision, and if that keeps getting worse, eventually it's going to lead to tunnel vision. It's a gradual onset, intermittent pain, halos around the light, especially during evening hours. And there can be other features such as headache, blurred vision, but it's not very common. In terms of investigations, you'll do a series of things. So a Goldman applanation tonometry, fundoscopy, and visual field assessment. And what you're aiming to do with the investigation is just to see the intraocular pressure. You're trying to see if there's any other pathology going on. And I do apologize, that should be visual field. And you just, because they have the peripheral vision is affected, so you want to see how badly is affected, are both eyes affected, and just get a better idea of what's going on. In terms of management, the first line will be prostaglandin analog eye drops, and an example of that is latanoprost. And I've highlighted that in red because that's an important management to know, especially for open angle glaucoma. That brings me to my next question. Which of the following is an uncommon side effect of latanoprost? So I'll open the poll for you. I can appreciate that it's not a question you would have come across earlier. So just have a guess and see if you have any idea. No, that's good. We're getting a few votes in. I'll give you like about 10 more seconds. Okay. So I'm sharing the results with you guys now. And it seems like we're tied at eyelash growth and eyelid pigmentation. And then we have a vote each for browning, dry eye, and not sure. To be fair, when I first came across it, I wasn't sure as well. So the actual answer is dry eye. All the others are common side effects of latanoprost, and that's why it's important to know about this treatment. So yeah, you can experiencing browning of the iris, eyelash growth, and eyelid pigmentation. And quite commonly, even as an exam question, you might see a patient coming in and she's complaining that her color of her eyes have changed and she's very worried, and she'll be on latanoprost. So yeah, so as I was talking about the management earlier, you're aiming to reduce the intraocular pressure. The treatment is usually started when your intraocular pressure is 24 or above. And the first line, as we said, is the prostaglandin analog eye drops. Those are the side effects. Other options, you have a whole host of other things you can try. All of them aim to reduce the intraocular pressure. But essentially, if your prostaglandin eye drops don't work, the next step would be to go for a surgery. And a trabeculectomy, essentially, you're aiming to relieve the pressure in the eye, and that's essentially what the surgery does. So we spoke a bit about open angle. Let's talk a bit about acute angle closure glaucoma. So this is an ophthalmological emergency. Risk factors, increasing age. So females are more likely to get this. And as opposed to open angle glaucoma, Chinese and East Asian ethnic origins are at a high risk. Shallow anterior chamber medication. So these are additional risks, but I think the two main ones are female and the ethnic origin. Clinical features, so usually it's unilateral. You're going to have someone presenting with a severely painful red eye. They might have blurred vision, they can have halos, and the patient will just appear unwell. So nausea, vomiting, headache, any other systemic features can be seen. On examination, so I've tried to highlight in red the key things you would see. So you see someone with a red teary eye, hazy cornea, decreased visual acuity, dilatation of the affected pupil, so that's a good one to know. Fixed pupil size and an abnormal shape. Usually it's vertical oval, but it can vary. And the pupil is unresponsive to light. And if you try to palpate the eyeball, it's going to feel firm. So if someone comes into you and you're suspecting acute angle closure glaucoma, the clinical presentation will be quite obvious. In terms of management, so you refer them same day for ophthalmology assessment. If let's say you're in primary care, you can do a few things beforehand. So lie the patient back without a pillow. If you're in a GP, you can possibly have pilocarpine eye drops, and then you give acetazolamide 500 milligrams. That's something standard. You would give them both, either in primary care or secondary care. And as required, you can give analgesia, antiemetics, so basically symptomatically treat the patient. Secondary care management, so first you want to reduce the pressure. So again, there's a whole host of drugs you can give, but the two main ones are the B2 and B3, so these two which I've highlighted. And the definitive treatment is laser iridotomy. That's again, so you're just trying to relieve the pressure and make sure that you can preserve the vision. Right, so moving on to case 3. Now we have Mr. Ali, who has been experiencing a gradual loss in central vision of the right eye. He has also complained of straight lines appearing wavy. A fundoscopy was performed, and the image is here. What key finding does the fundoscopy show? Just going to bring up the poll for you guys. Yeah. So again, it's a bit of a tricky question because we don't see a lot of fundoscopies, but just have a guess and see if you can figure out what it is. So I'll give you guys about 10 more seconds. We seem to be getting a few more votes in. Right. So the majority of you said drusen, which is correct. That is the answer. And I'm going to discuss in a second why it is. So the diagnosis here is age-related macular degeneration, AMD. Oh, sorry. So the fact that it's a gradual loss in central vision, and another characteristic finding is that the straight lines appear wavy. On fundoscopy, a key feature that you would see is drusen, and when you see that, it's safe to presume that the patient has macular degeneration. Papilledema, cotton wool spots, neovascularization, blood hemorrhages, these are all features you would either see in a hypertensive or diabetic retinopathy, but it's not one you would be able to see in age-related macular degeneration. And here on the fundoscopy, I've highlighted the drusen. So you can see these yellow round sort of spots all over these areas. I'm trying to move my cursor and hopefully you can see that. And they're basically sorts of lipids and proteins that form these substances called drusen. So if you have a small amount of them, it's actually normal. But if they're quite large and quite widespread, then that would be an indication for age-related macular degeneration. So it basically means that there's degeneration in the macula, which progressively leads to deterioration in your vision. There are two types. So the dry one is more common. You're seen in 90% of patients. The wet is only seen in 10%, but it's a more severe form of AMD. Risk factors, so age, smoking, white or Chinese ethnic origin, family history of cardiovascular disease. Your clinical features, so it's a gradual worsening of central visual field loss. You have reduced visual acuity and crooked or wavy appearance to straight lines. So these are quite characteristic to AMD. On examination, they'll have reduced acuity, scotoma, and drusen, as you can see in the fundoscopy earlier. And scotoma is basically a loss of central vision. So as you can see, there's central visual field loss, just another word sort of is scotoma for it. Investigations, you can do slit lamp, tomography, fluorescent angiography. But in terms of management, so you want to refer them to an ophthalmologist. If it's dry AMD, your management focuses on lifestyle. So you're trying to slow the progression. There's nothing you can do to stop it. So again, look at the risk factors. As the patient smoke, then try to control it. Cardiovascular disease is a risk factor, so control blood pressure and everything else on those lines. If it's wet AMD, you can try anti-VEGF medications. And why anti-VEGF works in wet AMD and not dry is because vascular endothelial growth factors play a role in sort of developing wet AMD. So if you use something that works against it, it's going to try and stop it. And I've given some examples of that. But if you just know the dry ones, those are the more common ones. So let's move on to case 4. I can appreciate we've got some questions. So we go through a couple more cases and then we take a break and try and answer some of the questions. So case 4, here you've got Josh Smith, who is a 14-year-old male. He presents to A&E with pain in his left eye. He is also experiencing pain in his left eye on movement. What is the most likely diagnosis? And you can see a picture of Josh right there. So I've opened the poll. Right, so I'm going to share the results of the poll, and we've got a tie between periorbital cellulitis and orbital cellulitis. And then we got a vote for calcium and a vote for keratitis. So the answer is orbital cellulitis, but it is a good differential to keep periorbital cellulitis second. And sometimes when the patient presents clinically, it's hard to differentiate whether it's orbital or periorbital, because from the outside they can look similar, but inside the things might be different. A Calician, we got to vote for a Calician. So Calician or styes, they won't look this bad. It might just involve either the upper or the lower eyelids. You won't see such gross inflammation and redness around the eye. And herpes keratitis, so again, that's what more you would present with a painful red eye, and you wouldn't have such gross swelling of the eye. We are going to talk a bit more about red eye, so hopefully the person who voted keratitis, that might get clearer. Yeah, so I've highlighted the pain in his left eye, pain on movements, and orbital cellulitis. So orbital cellulitis is basically infection around the eyeball, and it involves tissues behind the orbital septum. And I think that's a key difference that from periorbital cellulitis, where the infection is in front of the orbital septum. It is a medical emergency because it's sight-threatening. So if it isn't treated on time, the person could potentially lose their vision. There are 5 key features to remember with orbital cellulitis. So the first is pain on eye movement. The second is reduced eye movement. Then changes in vision, abnormal pupil reaction, and the last one is proptosis. And proptosis is just another word for exophthalmos. So in terms of management, any patient with orbital cellulitis, you must admit them to hospital and give them IV antibiotics, not oral. Plus minus a surgical drainage. So again, if you're suspecting an abscess, you would want to drain it. Okay, so moving on to periorbital cellulitis. As I said, the infection is in front of the orbital septum. So clinical features, you again see swelling, redness, hot skin. And like most of you, we had a tie on the questions. So a CT scan can help differentiate between orbital and periorbital cellulitis. And that's just basically going to show you whether it's the infections in front or behind the orbital septum. Management, again, you can either give them you have to give them antibiotics. Oral or IV will sort of depend on how unwell they are. Hospital admission is not necessary for patients with periorbital cellulitis. But however, if you feel like someone is really unwell, or if you feel like they might be a child, so a vulnerable patient, you can always admit them to hospital. It's always better to be safer. Right. Let's move on to case 5, and after case 5, we'll take a little break and see if there are any questions. So here we have Stephanie Clark, who is a 58-year-old lady. She presented with a loss of vision in the right eye. Stephanie said everything was fine, and then suddenly an hour ago, she couldn't see anything from her right eye. She is not experiencing any pain. Her past medical history includes asthma and giant cell arteritis. The fundoscopy of the right eye is shown below. What is the most likely diagnosis? So again, I can appreciate fundoscopy questions are a bit challenging, but have a go and see what you guys think. Sorry, I'm just putting on the poll in a second. So I'm just going to give you guys about 5-7 seconds more to answer anything. Yeah, okay. So the majority of you said central retinal artery occlusion, and that's correct. That is the correct answer. We got a couple of votes for retinal detachment and a vote for subconjunctival hemorrhage. So let's just discuss why it is what it is. Right. So So she's a 58-year-old lady. So those are sort of risk factors, along with giant cell arteritis, that make central retinal artery occlusion more likely. The fact that she experienced loss of vision and it was sudden, again, points to the fact that it's an occlusion. And a key thing to remember is that she isn't experiencing any pain. So in terms, yeah, none of you voted for acute angle closure glaucoma. That's good because there's pain there. Retinal vein occlusion, it's a good diagnosis to have. So had you not had the fundoscopy, it could have been either number 3 or number 4. But this fundoscopy is characteristic of central retinal artery occlusion. So you see a cherry red spot here, you see a pale retina, and you're going to think it's an artery occlusion. We got a vote for retinal detachment. So again, that's a good differential to have, but someone with retinal detachment will have a peripheral loss of vision. It's going to be sudden, but it's more peripheral. So here it just says loss of vision in general. And subconjunctival hemorrhage, we do have a case about this later, but showing you the fundoscopy won't reveal anything. And you're going to see if you see someone's eye from the outside, you'll actually be able to sort of you differentiate and say, oh, that's an hemorrhage. So a fundoscopy is not going to be relevant. Yeah, so yeah, an important thing I highlighted here is the anatomy. So, you must know where the artery arises from. So the internal carotid artery gives rise to the ophthalmic artery, which then gives rise to the central retinal artery, and that supplies blood to the retina. Atherosclerosis is the most common cause of occlusion. You are at an increased risk if you have conditions such as giant cell arteritis, especially if they're female above 50, or polymyalgia rheumatica. Risk factors, they're the same as cardiovascular disease, so there's a whole host of them there. Clinical presentation, so it's sudden, painless loss of vision. They can have a relative afferent pupillary defect, and you usually see a pale retina with a cherry red spot on fundoscopy. And that's an exam favorite for them to ask. Management, so you want to refer them to ophthalmology immediately. There are a few other options I've put here, but I've said limited evidence. So ocular massage, carbogen, isosorbide. So you can, sometimes doctors do try them, but do they actually work? We're not really sure. Long-term management, so you're treating reversible risk factors. So if they do have conditions such as giant cell arteritis or rheumatica, you want to treat that. And secondary prevention of cardiovascular disease. Yeah, so that's that. And yeah, so before we move on to case 6, I'll give you guys a few minutes to ask any questions that you might have, and I'll try my best to answer them. Right, okay, so we got 2 questions here. Can you please explain what halos are? So halos are, imagine you have a light source, and when you look at that light source, you can, around that eye, you see sort of, you can see the light rays, but blurry. So just like a circle around the light, which is blurry. Yeah, it's not the best explanation, but if you search halos, you might be able to get a better idea. And can you go over the differences between wet and dry AMD? Sure. So again, wet AMD, a key thing to remember is that vascular endothelial growth factors play a role in their development. So that's why in terms of managing them, you're going to use anti-VEGF medications, as opposed to dry AMD, whereas your natural risk factors such as age, cardiovascular risk factors, etc., can play a role in that. And so with dry AMD, that's why there's no particular medication, and it's more just on treating the risk factors and treating your symptoms. I hope that answers your question. Okay, I think we have another question coming up. Is myopia a risk factor for acute angle closure glaucoma? Hypermetropia is a risk factor. I am not sure about myopia. At the end of the session, I can check that for you. And maybe I can email them and they can let you know that. So I'm sorry I couldn't answer that question. Right. So if we don't have any more questions at the moment, let's proceed. The next 4 cases are going to be about red eyes. And again, after the end of that, if you have any questions, we'll stop and then you can ask me. So let's talk about case 6. So we have Caroline here, who is a 55-year-old female, and she's presented to general practice with redness of her left eye. She has not been experiencing any pain, but has complained of the left eye being itchy. She had a sore throat last week, but has been feeling better now. Considering the diagnosis, what treatment option would you advise? And I've launched the poll for you guys, so have a go at that. All right, so we got quite a few votes coming in. I'm going to give it like 5-6 more seconds for you to vote. Okay. All right, so the majority of you said antihistamine, and then we've got a tie between antibiotic eye drops, warm water compressed, and mast cell stabilizers. We've got no votes for steroids, so that's good. Right, so let's discuss what it is. So the diagnosis here is viral conjunctivitis. And the answer is warm water compress. But we'll talk a bit about why it is warm water compress. So the fact that Caroline has had redness of her left eye, there's no pain, and it's been itchy, at this point, it would be a safe assumption to say, oh, she has conjunctivitis. Now, coming down and thinking what type of conjunctivitis, the fact that she had a sore throat last week can sort of make you think, oh, maybe it's something viral going on. And usually someone with viral conjunctivitis might have a sore throat or features of an upper respiratory tract infection, and then they develop conjunctivitis. If she had, so the first option, antibiotic eye drops, would be applicable if she had bacterial. And here, well, the fact that she had a sore throat, there's no pus, no sticky eyes, it would be a viral conjunctivitis would be more likely. Antihistamines and mast cell stabilizers are both options you can use if you have an allergic conjunctivitis. And had she not had a sore throat, possibly if the question mentioned that during some season she gets worse or during this time of the year, you might be thinking of allergic conjunctivitis, but there was no indication of that. Warm water compress. So for viral conjunctivitis, the treatment would just be symptomatic. And in general, you would advise them of good hygiene, so that means not sharing towels, etc., and a warm water compress sort of alleviate the symptoms, and that's why that's the option. I hope that makes it clearer, but if there's a question, just pop it down on the chat box. So talking a bit about conjunctivitis, 3 types. We have bacterial, viral, and allergic. In general, the presentation can either be unilateral or bilateral. You see someone with red bloodshot eyes. They might have a gritty or itchy sensation, and you can also see discharge from the eye. Conjunctivitis does not cause pain, photophobia, or reduced acuity. So that's important to remember, because later on we're going to see red eyes, which might be sight-threatening, and you should have an idea of how to differentiate between a sight-threatening and a non-sight-threatening red eye. In bacterial, you would see a yellow discharge. In viral, it's a clear discharge, and allergic, you see a white discharge. Specific features, so bacterial is usually worse in the morning, and your eyes can get sticky. It's highly contagious. Similarly, even viral is very contagious, and they might have features of a viral infection, so sore throat, dry cough, etc. Allergic, you have a seasonal presentation, and it's not contagious at all. Management, so bacterial, you want to give antibiotic eye drops. Chloramphenicol is an example. Fusidic acid is another one. Viral is self-limiting, and antihistamines, either oral or topical, is for allergic. I did say mast cell stabilizers, so you can give those as well, but the first line is always antihistamines for allergic conjunctivitis. So in general, someone with conjunctivitis, regardless of which one they may have, you want to give them advice on good hygiene, so avoid sharing towels, avoid using contact lenses, and clean the eyes with cooled boiled water and cotton wool. And if it's someone with viral, that's the only advice you would want to give them. So again, features such as discharge, and they don't always have to be there if someone has conjunctivitis. You usually just, commonly you might just see someone who's got red eyes and they feel itchy. A good thing to do is safety net them. So if you see someone with viral conjunctivitis and they're not getting better in a while, you can possibly ask them to come back, see if it's a bacterial, and then you can maybe prescribe them some eye drops. Moving on to case 7. So here we have John, who presents to the general practice with redness in his right eye. He is painless and his vision is unaffected. His left eye is unaffected. He has a past medical history of hypertension and gout. What is the most likely diagnosis? So I've launched the poll. Have a go and see what you guys think. So I'll give you guys about 10 more seconds to answer the question. We've got quite a few words coming in. Okay, right, so it's great. The majority of you said subconjunctival hemorrhage, which is the right answer. And we got a couple of people saying keratitis. So let's discuss why it is subconjunctival hemorrhage. Okay, so John presents with redness in his right eye. The fact that it's painless and his vision is unaffected points you to subconjunctival hemorrhage. There are certain conditions that increase your risks, such as hypertension. So that's why I've highlighted that. And if you just simply forget all the history and just look at the patient, you can see that it looks like bright red blood, and that's easy to appreciate. And subconjunctival hemorrhage is one of those diagnoses which will be relatively easy to spot because it looks like blood in the eye. Keratitis would present with a painful eye, which is not present in John's case. Scleritis and corneal abrasion also present with a painful red eye. And we just spoke about conjunctivitis earlier, but none of you voted for that, so that's good. So subconjunctival hemorrhage. In general, the majority of cases are idiopathic. Certain conditions can predispose you. So these are conditions such as hypertension, whooping cough, you have a bleeding disorder. And I made there's a note of these in the notes section of the PowerPoint, so you guys can have a read of that. Clinical presentation, you usually see a patch of bright red blood that covers the white of the eye. It's painless, it doesn't affect the vision, and there can be precipitating factors. So any heavy lifting, if they were having a coughing fit, that can usually cause an hemorrhage. Management, so subconjunctival hemorrhages are harmless and they will resolve spontaneously without treatment in approximately 2 weeks. And if you want, you can investigate possible causes. So if you think, or could this patient have hypertension? Could this patient have another disorder? You can investigate those. Sometimes people with subconjunctival hemorrhage feel like their eyes are dry, so you can give lubricating eye drops, but usually it just goes away on its own in 2 weeks. Let's go on to case 8. So here we have Marvin Smith, who's a 34-year-old gentleman, and he's presented to the general practice with a 2-day history of sudden onset dull pain in his left eye. He has also noticed that his left eye is red and experiences discomfort when looking at bright lights. He has a past medical history of ankylosing spondylitis. On examination, there's a constructed pupil in the left eye. Given all this information, what do you believe is the most likely diagnosis? So this question is quite wordy, so I'll give you about 30, 40 seconds. Let me know what you guys think. So that's good. I'll just give a few more seconds to get a couple more votes in. Okay. So I have to say, you guys are doing a fantastic job. We got anterior uveitis as the votes with 100% of votes, and that is the correct answer. So, but let's just discuss a little bit about why it is. So anterior uveitis, one thing to know is that the risk factor is conditions related to HLA-B27. And this person, Marvin Smith, has ankylosing spondylitis. And you typically would see that in someone who's a 34, who's like a young male, presents with back pain. Talking particularly about the eye, you see a sudden onset of dull pain, and you get discomfort when when looking at bright lights. So basically photophobia. On examination, you will see a constricted pupil, and all these things point to anterior uveitis as the most likely diagnosis. I know no one voted for the other examples, but just sort of going through them. There's nothing in the history to suggest there could be foreign body or trauma to it. Keratitis, again, yes, it can present with a painful red eye, but you have a few risk factors that make anterior uveitis more likely. And corneal abrasion, again, you'd see something would precipitate a corneal abrasion. So maybe using contact lenses, getting a cut, but there's nothing in the history to suggest such a thing. Anterior uveitis is also known as iritis, and sometimes textbooks use one or the other, so it's good to know that. It's usually due to an autoimmune cause, but there can be other things such as infection, trauma, malignancies that trigger it. So about 50% of the cases you see would be due to an autoimmune cause. It can either be acute or chronic, and chronic is basically more than 3 months in this case. So HLA-B27 conditions are associated with acute anterior uveitis. So as mentioned, ankylosing spondylitis, but things like IBD, reactive arthritis can also be present. These are not the only conditions that increase your risk, so it might be worth having a little bit of a read of risk factors for anterior uveitis. Clinical presentation, so usually you see someone who's young and middle-aged, and there's a whole host of things you can see, and it does look like quite a few things, but I've highlighted in red the more common things. So it's usually unilateral. You get a dull, aching, painful red eye. You get ciliary flush, might experience photophobia, a reduced visual acuity, constricted pupil, lacrimation, and abnormally shaped pupil. Might also experience a couple of the other things, but the main things are the ones that are highlighted in red. And in terms of the management, so again, you want to send them for same-day ophthalmology assessment. And when you do, they'll do a slit lamp, they'll check the intraocular pressure. In terms of medication, so options are steroids, cycloplegic, mydriatic medications, and immunosuppressants. And if it's very severe, there are other things that can be considered, such as laser therapy, cryotherapy, or surgery. Okay, and I hope that makes that clear. Coming to case 9, and you've got Sarah, who's a 34-year-old female, and she presents with a very painful left eye. She has also been experiencing photophobia and lacrimation. Her right eye is unaffected. Given the likely diagnosis, what is the next step in managing Sarah? So I'm going to open a poll for you guys. and take about 30 seconds and see what you guys think. Okay, so I'm getting a few more votes in. I'm going to wait a few more seconds for you guys. Right, so the majority of you said same the ophthalmology assessment, and that's correct. That's the first thing we're going to do. And then we're split between all the other options. So let's discuss why we'd refer them as the first thing. So someone who's presented with a very painful left eye, they've come in with photophobia and lacrimation. So it's safe to assume that it is something very severe. You would want to refer them to ophthalmology. You would want to see, because if someone's coming with a red eye, the key thing to differentiate is it a sight-threatening or a non-sight-threatening red eye. And usually, usually conditions which do affect your sight do present with pain. And additionally, she has photophobia and lacrimation. So it's safe to say refer them to ophthalmology just to make sure nothing sinister is going on and they can get that sorted. In terms of referral to A&E, that wouldn't really help because they would again have to refer them to ophthalmology and you're basically prolonging the whole process. Giving them analgesia, yes, that's an option. You can give them analgesia. They may have already taken analgesia. But it's not but as a doctor, the first thing you would want to do is refer them to ophthalmology. Steroids and NSAIDs, yes, they can have a role in the management of the condition, but unless you actually get to know what it is and how to treat it, there's no point giving all these medications. So the diagnosis in this case is scleritis, and it's associated with systemic conditions, so rheumatoid, SLE, IBD, and a whole host of things. Clinical presentations, that's very common in older women, and it's acute onset. It can be unilateral or bilateral. Someone presents with severe pain, reduced visual acuity, abnormal pupil reaction to light, pain with movements moving the eye, and tenderness on palpation, and lacrimation and photophobia. So an important complication to note of scleritis is perforation of the sclera. And in terms of management, we want to refer them to ophthalmology. As you guys said, NSAID, steroids, all reasonable treatment options, and consider is there any systemic underlying condition that has predisposed this patient to develop scleritis. Right, guys, you have been fantastic throughout this whole presentation. The take-home messages I would say is have a read, look at what are the sight-threatening causes of red eye, and when you see someone with that, refer them to ophthalmology. This is not an exhaustive list of conditions, so read around the area and know the basic anatomy of the eye. Understanding the anatomy makes it easier to differentiate between different clinical conditions. And I would really appreciate if you guys just take a minute out and fill in this feedback form. In the meantime, I'd be happy to answer any questions you may have. So you got a couple of questions here. Does bacterial conjunctivitis always need treatment? Is it not often self-limiting? So usually if you do have someone with bacterial conjunctivitis, you do have to give them eye drops. It is not self-limiting. If you have, however, if you do have like a query, whether it's bacterial or viral, then you can wait and watch, but you do give them eye drops. And the second question is, would an antihistamine not ease the itchy symptoms of viral conjunctivitis? So you are right, yes, you can give someone with viral conjunctivitis, they can possibly be given antihistamines, but what's important to note is that antihistamines have side effects such as drowsiness, dry mouth, and usually patients don't like that. So that's why if you just give them general advice and tell them warm water compress, that should help ease their symptoms without actually taking a drug. But antihistamines can be given in viral conjunctivitis. I hope that answers your question. Yeah, and if you guys have any more questions, just feel free to hit up the chat box. Otherwise, thank you very much for attending. And those are the resources. So all the images are referenced. I use Zero to Finance and lecture notes in ophthalmology. Right, so we got a question if I could briefly explain retinal detachment. Yeah, of course. So retinal detachment is, again, it's another sight-threatening emergency and it's painless. It's basically when the retina separates from the choroid underneath. And this is usually due to a retinal tear, which allows the vitreous fluid to get under the retina and fill the space between the retina and the choroid. So essentially, it's a sight-threatening emergency, and you need to recognize it quickly and treat it. There are a number of risk factors, and these are things like trauma to the eye, if you have a malignancy, old age. In terms of presentation, so I think a key thing to note is that it's a peripheral loss of vision, and it's a sudden peripheral loss of vision, which is help differentiate it from things such as glaucoma. You can experiencing a blurred or distorted vision. The patient can also have flashes and floaters roaming around. In terms of management, so refer to ophthalmology, and they're either going to do there's a number of things you can do. So either laser therapy or different types of surgeries. And the aim of that is just sort of to attach the retina as fast as you can to prevent any complications. I hope that answers your question. And thank you all for attending and saying the session was great. It's always good to hear that.